Dr. Dlamini, I have exciting news. Did you hear that there's a new ARV called dolutegravir that's been added to our national guidelines? It will be available as a fixed dose combination with two other drugs known as TLD.
TLD, but we're already using the TEE fixed dose combination. What's the difference?
The difference is that TEE has efavirenz and TLD has dolutegravir as the third drug.
I've been hearing a lot of things about this new drug dolutegravir. What are the benefits?
Dolutegravir or DTG is a real game changer. It provides rapid viral suppression, high genetic barrier to resistance, no interaction with hormonal contraceptives, and the big advantage is that side effects are mild and uncommon, so it's easier for people to keep taking their medications and stay in care.
You said side effects are generally mild and uncommon, but what are some of them?
People may experience insomnia, headaches, and gastrointestinal disturbances.
Dolutegravir sounds like a great medication that will encourage adherence and really help people to get their viral loads suppressed. But are there any associated risks to dolutegravir that I need to know about?
Yes, dolutegravir is associated with a low risk of neural tube defects when used around the time of conception and in the first 6 weeks of pregnancy when the neural tube is still open. By the end of 6 weeks, the neural tube closes and there's no longer a risk of neural tube defects after this period. The other risk to keep in mind is the issue of drug-drug interactions. We need to consider TB, diabetic, and anti-epileptic medications, and also medicines containing polyvalent cations such as calcium and iron supplements and certain antacids. The latter is especially important in our pregnant women on ART.
But this risk of neural tube defects in the first trimester of pregnancy concerns me. What is the real story there?
Well, in May 2018, an ongoing study in Botswana raised a safety signal for the possible risk of neural tube defects, like spina bifida in babies conceived while their mothers took DTG. In July 2019, additional data was released that showed a much lower incidence of neural tube defects than initially anticipated, with most cases occurring in non-folate fortified countries, unlike South Africa, which is folate fortified. The absolute risk is very low and translates to a risk difference of 2 additional neural tube defects per 1,000 periconception exposures to dolutegravir, a 0.3% risk, compared to efavirenz at conception, a 0.1% risk. Nevertheless, the seriousness of neural tube defects makes it necessary to be cautious in those women who are actively wanting to fall pregnant on dolutegravir, or women early on in pregnancy before the neural tube has closed.
Oh, okay. So what is the standard dose of dolutegravir?
For adults, adolescents, and children weighing 20 kgs or more, the standard dose is 50 milligrams once daily. It can be taken either in the morning or in the evening, depending on the client's preference. Dolutegravir is available in the fixed dose combination we mentioned before with tenofovir and lamivudine, known as TLD. However, because of weight and age restrictions on the tenofovir component of TLD can only be used in clients 10 years and older and weighing 35 kgs or more.
That's good to hear. I know from experience that fixed dose combinations do really make it easier for our clients to adhere to their ART. So what are the next steps? Which adults should be initiated on or switched to TLD?
Firstly, TLD will now become the preferred first-line ART regimen for all new male and female clients initiating ART, weighing 35 kgs or more, and who are 10 years and older. Secondly, because of TLD's great benefits, we would like to switch existing clients on first-line ART to a DTG-containing regimen as well, but they can only be switched if they have a viral load of less than 50 copies per milliliter in the last 6 months. This is to make sure that we do not switch only one drug in a failing regimen.
Does that apply to pregnant women too?
Great question. So, because of new data showing us that the risk for neural tube defects is actually very low, the World Health Organization has recommended the use of dolutegravir for first-line ART in all women and men without exception. However, in South Africa, we have opted to be a little more cautious. TLD is a preferred first-line regimen in all women, with the exception of only the following 2 scenarios. 1. Women who currently want to conceive, and 2. women who are initiating ART in the first 6 weeks of pregnancy. But remember, while we as healthcare providers can recommend a certain regimen, we have to respect the women's right to be provided with all the necessary information and to make an informed choice.
So, what exactly are the steps I need to follow to be able to help a woman to make an informed choice?
Firstly, we have to understand her current pregnancy status and fertility intentions. If she's pregnant, we need to know her gestation. If she's not pregnant, we also need to determine if she actively wants to conceive at the present time. Secondly, we need to provide her with all the necessary information, including the risk of neural tube defects for current or future pregnancies. Thirdly, we need to discuss and provide a choice of contraceptive options as desired, keeping in mind that the dual methods are recommended for any woman of childbearing potential who is not planning to fall pregnant, including women on DTG. Lastly, having received all this information, the client should now make an informed choice as to the regimen she would like to use. Record this choice in the client's file, also noting the counseling she received, her understanding of the risks, and the contraceptive option she has opted for.
What about children and adolescents?
Children weighing 20 kgs or more can initiate a DTG-containing regimen. However, due to the age and weight restrictions on tenofovir, they will not yet be eligible for TLD. They will need to use abacavir, lamivudine, and dolutegravir. In contrast, adolescent boys and girls 10 years and older and who weigh 35 kgs or more qualify for tenofovir, provided that they have a normal renal function. They can therefore also use TLD.
What about switching them?
Yes, absolutely. Adolescent boys and girls weighing more than 35 kgs and being 10 years of age with a normal renal function and a viral load less than 50 copies per milliliter can now be switched onto TLD as well. Remember, of course, that the child's age, weight, and current regimen is important in determining who can be initiated or switched. Have a look at this table to see which regimens apply to children and adolescents starting ART or switching regimens.
What about my other patients? Can people taking TB treatment be initiated on TLD?
Yes, they can. But what is important to remember is that if the client is also using TB medication, we need to double the dose of DTG to counteract the drug-drug interaction. That means taking the normal 50 mg dose of dolutegravir within TLD at the regular time, and then taking a single 50 mg tablet of dolutegravir 12 hours later. Your clients that are taking MDR TB treatment can also be initiated on TLD. It can also be taken together with TB preventive therapy like INH without any adjustments.
Final question. Can dolutegravir be used for current first-line failures? Like, for example, efavirenz containing regimens with 2 viral loads over 1,000 copies per milliliter?
Yes. The difference here is that we will not be switching only one drug in the failing regimen, but rather the full regimen to standard second-line treatment, which will be zidovudine, lamivudine, and dolutegravir. Oh, and by the way, the National Department of Health has a great online resource called the Knowledge Hub. You can log in there to get the new clinical guidelines and other very helpful tools for healthcare workers. I took an online course about TLD on this site and it was really helpful. Go check it out at www.knowledgehub.org.za/LMS.
Fantastic. Thank you. This has been very helpful. This is great news for patients and clinicians.